It's time for the 3-question warm-up for Renal 4. Let's get going. Which bacteria secrete enterotoxins? So you need to think about Vibrio cholera. You need to think about enterotoxigenic E. coli. It's making that heat labile toxin that causes very similar diarrhea to cholera. Staph aureus has a series of enterotoxins. Shigella, Yersinia, and the Clostridium species, specifically Clostridium difficile and also Clostridium perfringens. Next question. What is Charcot's neurological triad? So remember, this is scanning speech, intention tremor, and nystagmus. Next question. What organisms are most commonly implicated in subacute endocarditis? So think of viridin streptococci, enterococci, and then sometimes the coagulose negative staph, specifically Staph epidermidis. All right, guys, that's it for the warm-up. Let's get to that lecture now.
In this video, we're going to talk about diuretics. Now, diuretics are very high yield. You need to know how they work and where they work. We're going to discuss the various classes of diuretics according to their site of action within the nephron from proximal to distal. So the most proximal part of the nephron is the proximal convoluted tubule. And the diuretic that works here first is acetazolamide. Now, acetazolamide is a carbonic anhydrase inhibitor. Remember, we talked about carbonic anhydrase in the lumen of the proximal tubule converting bicarb to CO2 and water, which can then be reabsorbed. So if you inhibit carbonic anhydrase, you can't reabsorb bicarb, so you excrete it in the urine. So acetazolamide does have a minor diuretic effect, but we mainly use it not for its diuretic properties, but to facilitate excretion of bicarbonate. So when would you want to excrete bicarbonate? Well, one condition is altitude sickness. So think back to the pulmonary video where we talked about high altitude medicine. If you're at a high altitude, the partial pressure of oxygen is lower, so you're going to have to breathe faster and deeper in order to oxygenate, right? You're going to increase your ventilation at high altitude. Well, when you increase ventilation, you're blowing off CO2. When you blow off a lot of CO2, you're going to eventually develop a respiratory alkalosis. Now, eventually, over time, your body is going to compensate for that respiratory alkalosis by getting rid of bicarbonate, but that can take days. So, if you have a patient with altitude sickness, you can give acetazolamide and help them excrete bicarbonate and overcome that respiratory alkalosis more quickly. We can also use acetazolamide to alkalinize the urine because all that bicarb in the urine makes the urine more alkaline. Or we could use acetazolamide to treat metabolic alkalosis and help the body get rid of bicarbonate that it needs to. We also use acetazolamide to treat chronic glaucoma because bicarb production draws water into the eye to form aqueous humor. So blocking bicarb production reduces production of aqueous humor and it reduces the intraocular pressure. Then for the side effects, acetazolamide can cause metabolic acidosis. Even if you just use acetazolamide eye drops for glaucoma, it can still cause a metabolic acidosis. You're losing bicarb in the urine and you're becoming more acidotic. And then it's also a sulfa drug, so it can lead to sulfa allergy. So if you have a patient with a sulfa allergy, you don't want to give them acetazolamide. Lots of different diuretics we're going to talk about are sulfa drugs. You need to pay attention to that. Next up is mannitol, which also works in the proximal convoluted tubule. Mannitol is an osmotic diuretic. So mannitol causes an osmolar load that stays in the filtrate and prevents reabsorption of free water in the proximal tubule. It causes excretion of free water. Now, obviously, mannitol will raise serum osmolarity. But what does mannitol do to serum sodium? Well, you're losing free water, so the serum sodium is going to rise a little bit. Now, in terms of side effects, mannitol can cause dehydration because you're losing free water. And it's contraindicated in patients with anuric renal failure and in patients who have congestive heart failure. Now, we don't really use mannitol very often. Occasionally, you're going to see it used to treat shock or to treat drug overdoses. Sometimes we use it to lower intraocular pressure in patients with acute angle closure glaucoma. So remember, there are two diuretics that can be used to treat glaucoma. One of them is acetazolamide. The other one's mannitol. So we just mentioned acetazolamide can be used to treat chronic glaucoma, but mannitol is used for acute glaucoma. Mannitol is also sometimes used to treat elevated intracranial pressure, not really because of its actions in the kidneys, but because of its actions elsewhere. So if you give IV mannitol, it's going to go into the circulation, it's going to draw interstitial fluid into the vasculature to balance that intravascular osmolar load. So fluid is going to shift out of the swollen brain tissue if you have intracranial pressure that's elevated. The next group of diuretics is the loop diuretics, including furosemide, but there are some other loop diuretics too that you should know about, including bumetanide and torsemide. Now, all three of these are sulfonamide loop diuretics. There's another loop diuretic called ethacrynic acid, which is not a sulfonamide. But again, furosemide, bumetanide, torsemide, they're all sulfonamides. They're all going to be contraindicated in patients with sulfa allergies. Now, where in the nephron would you guess that loop diuretics work? Well, in the loop of Henle, obviously. Remember, these drugs inhibit the sodium chloride potassium cotransporter in the thick ascending limb of the loop of Henle. So if you can't actively pump out all those electrolytes out of the filtrate into the interstitium of the medulla won't be so hypertonic, which means that back in the thin descending limb, you won't be able to concentrate the urine. So the urine is going to end up more dilute than it would be otherwise, even though there's lots of sodium and potassium and chloride in it. And loops also increase calcium excretion. So loops lose calcium. Loops lose calcium and thiazides retain calcium. Remember that whole phrase, loops lose calcium, thiazides retain calcium. So if you have a patient with hypercalcemia and you want to lower serum calcium, you could reach for a loop diuretic. If you want to retain calcium, you can reach for a thiazide diuretic. So when do we use loop diuretics? They're mainly going to be used in patients with serious edema, CHF, pulmonary edema, nephrotic syndrome, cirrhosis. Anytime you want to get rid of a lot of fluid relatively quickly, you reach for a loop diuretic. They're some of the most potent diuretics we have. Now, loops are not commonly used for hypertension. They do reduce blood volume, they do reduce blood pressure some, but it's much more common to treat hypertension with a thiazide diuretic than with a loop diuretic. Then for the side effects of loop diuretics, you can see ototoxicity and nephrotoxicity, similar to the aminoglycosides and also similar to vancomycin. So if you give a loop diuretic plus an aminoglycoside, you can really increase the risk of ototoxicity and nephrotoxicity. Hypokalemia is another important toxicity of loop diuretics you should know about. Patients on loops are going to be excreting a lot of potassium, and they could potentially become hypokalemic. And obviously, when you're losing a lot of fluid, you can become dehydrated. Loops can precipitate gout because they interfere with uric acid excretion, and we already mentioned the possibility of a sulfa allergy. Now, what was the loop diuretic I mentioned that was not a sulfa drug? Ethacrynic acid. So, if you have a patient who needs a loop diuretic but who has a sulfa allergy, you might reach for ethacrynic acid. That's really about the only time you're going to use ethacrynic acid. Next, let's talk about the thiazides. Thiazide diuretics include chlorothiazide, hydrochlorothiazide, chlorthalidone, metolazone. There's a ton of thiazides. But hydrochlorothiazide is the most widely used one, and it's commonly just abbreviated HCTZ. Now, the thiazides are probably the second most potent class of diuretics. They work by inhibiting sodium chloride reabsorption in the distal convoluted tubule, so they reduce the diluting capacity of the nephron. You're losing a relatively high electrolyte fluid in the urine. And as I mentioned, thiazides retain calcium. They decrease calcium excretion, so you have less calcium in the urine and more calcium in the serum. So this can be useful if you have a patient who's at high risk for developing osteoporosis, who also happens to have some hypertension. So you can start a thiazide diuretic, and that's going to lower the patient's blood pressure. It may also help prevent osteoporosis because it raises the serum calcium a little bit and prevents calcium excretion. But the main clinical use of thiazides is for hypertension, as we mentioned back in the cardiovascular section. Remember that the ALL-HAT study showed that the thiazide chlorthalidone was better at reducing the risk of strokes. So thiazides are generally your first-line treatment for essential hypertension. On the other hand, it's much less common to use thiazides for CHF. Usually you're going to use a more potent diuretic, like a loop diuretic. You might use thiazides for idiopathic hypercalciuria. So say you have a patient that has normal serum calcium, but who dumps a lot of calcium into the urine, and that leads to calcium stones. A thiazide diuretic might help stop this because it's going to prevent some of that calcium from going into the urine. But if you have elevated serum calcium, maybe a patient with hyperparathyroidism, and that elevated serum calcium is causing a lot of the calcium to spill over into the urine, you don't want to use a thiazide in that situation because the thiazide is only going to make the hypercalcemia worse. So you don't want to give a thiazide to a patient with hypercalcemia. But if they have idiopathic hypercalciuria, you can give a thiazide to that patient to prevent those stones. And then thiazides are also going to be used to treat nephrogenic diabetes insipidus. For the side effects, thiazides can cause hypokalemia, again, very important. They can cause hyponatremia, or low sodium. They can cause hyperglycemia, hyperlipidemia, hyperuricemia and gout, and also hypercalcemia. Remember, we said loops lose calcium, thiazides retain calcium. And then again, thiazides are also sulfa drugs, so you want to avoid them in patients with sulfa allergy. Our last group of diuretics are the potassium-sparing diuretics. which we said work in the collecting tubules primarily. And remember, all potassium-sparing diuretics are not created equal. They share a common feature, which is that they all spare potassium. And instead of promoting potassium loss, like the loop diuretics and the thiazides, the potassium-sparing diuretics actually help potassium to stick around. So last year, a student sent in a great mnemonic for these drugs, which is potassium, please have a seat, because you want potassium to stay put. So seat stands for spironolactone, eplerenone, amiloride, and triamterene. Now, spironolactone and eplerenone are both aldosterone antagonists. Amiloride and triamterene block sodium channels, but they do not antagonize aldosterone. They work a little bit differently. So if you have a patient who has hyperaldosteronism, you might want to use spironolactone or eplerenone. So think about it. In hyperaldosteronism, you're retaining sodium, you're spilling a lot of potassium, you're wasting potassium, so you can use an aldosterone antagonist to correct that and counteract those electrolyte imbalances. Now, we also sometimes use potassium-sparing diuretics, especially triamterene, concurrently with loop diuretics or with thiazide diuretics. So say you have a patient with CHF and you start furosemide, and then the patient starts getting hypokalemic. Well, you can give a potassium-sparing diuretic along with the loop diuretic in order to retain some potassium and prevent that hypokalemia. And then in CHF, we talked about how the aldosterone antagonists have been shown to reduce morbidity and mortality in these patients with heart failure. So we can use these in low doses in patients with CHF. We said, remember that the patient with CHF needs to be on several drugs. They need to be on a specific beta blocker, they need to be on an ACE inhibitor or an ARB, and they need to be on one of these aldosterone antagonists. So again, those are the drugs that have been proven to increase survival and reduce mortality in CHF patients. And then if that CHF patient is also having fluid retention, they most likely need to be on a stronger diuretic as well. So what about the side effects of potassium-sparing diuretics? Well, obviously, retention of potassium could lead to hyperkalemia, which can lead to arrhythmias like VTAC or VFib. You should also know that spironolactone is structurally similar to sex hormones, so it can antagonize androgen receptors and cause gynecomastia in men. Remember the mnemonic stacked for the drugs that cause gynecomastia? Well, the S was for spironolactone. And occasionally we use these anti-androgen effects therapeutically. We might give spironolactone to treat acne or to treat polycystic ovarian syndrome, or PCOS. And then another endocrine effect is that spironolactone also has some progesterone agonist activity, and that can lead to menstrual irregularities in women. Now, it's worth noting that eplerenone is much more specific for the mineralocorticoid receptor. It doesn't really bind to the androgen receptor the way spironolactone does. So you're not going to get the anti-androgen effects with eplerenone the way you do with the spironolactone. Before we wrap up, I want to briefly review some of the electrolyte and pH changes associated with these various diuretics. So virtually all diuretics will increase urinary sodium chloride, with the exception of acetazolamide. All of them are going to increase urinary potassium, except for the potassium-sparing diuretics. And you can get hypokalemia as a result of most of these other diuretics. And then for acid-base balance, we discussed how carbonic anhydrase inhibitors will cause some metabolic acidosis. You can also get some acidosis with the potassium-sparing diuretics. But with the loops and the thiazides, as you lose lots of sodium chloride in the urine, you're becoming slightly hypochloremic. And that hypochloremia results in reduced excretion of bicarb. When there's more bicarb in the serum, that's alkalosis. And this is sometimes mistakenly called contraction alkalosis, as in the patient becomes volume contracted from using a lot of diuretics, or they become volume contracted from prolonged vomiting. But the truth is, it's probably hypochloremia that's driving the alkalosis. All right, so that's it for the diuretics. Now it's time for the end of session quiz. So go ahead and answer those, and then we'll go through the answers. All right, first question. What type of diuretic is each of the following drugs? So again, it's not enough to simply recognize these drugs as diuretics. You need to know what kind of diuretics each one is. So triamterene is a potassium-sparing diuretic. Acetazolamide is a carbonic anhydrase inhibitor. Hydrochlorothiazide, it's pretty easy, it's a thiazide diuretic. Bumetanide is a loop diuretic. Spironolactone is a potassium-sparing diuretic, more specifically an aldosterone antagonist. Chlorothiazide, again, is a thiazide diuretic. Ethacrynic acid is a loop diuretic, and specifically it's the one that's not a sulfa drug. Mannitol is an osmotic diuretic. Metolazone is a thiazide diuretic. Chlorothalidone is a thiazide diuretic. Furosemide is a loop diuretic. Amiloride is a potassium-sparing diuretic. And torsemide is a loop diuretic. Next, what diuretic or class of diuretic would be most useful in each of the following situations? So for acute pulmonary edema, remember we said that for heart failure, which is where you're classically going to have acute pulmonary edema, we have the mnemonic no lip, and the L in that no lip was for loop diuretics. The next bullet says idiopathic hypercalciuria resulting in calcium stones. This is where you might want to give a thiazide to reduce renal calcium excretion. So again, loops lose calcium, thiazides retain calcium. Glaucoma would either be acetazolamide or mannitol, depending on what kind of glaucoma you're dealing with. Mild to moderate CHF with expanded extracellular volume. So if this is really mild, you might use a thiazide, but classically with heart failure patients, you're going to use a loop diuretic. In conjunction with loops or thiazide diuretics to retain potassium, that would be any of the potassium-sparing diuretics. Edema associated with nephrotic syndrome, usually you're going to reach for a loop diuretic. Increased intracranial pressure, you're going to go for mannitol again, not for its diuretic action, but to act as an osmolar load that's going to draw that fluid out of the brain interstitium. Mild to moderate hypertension, a thiazide is generally going to be your first-line drug for hypertension. Hypercalcemia, you're going to reach for a loop diuretic to lose the calcium. For altitude sickness, you're going to use acetazolamide. And for hyperaldosteronism, you'd use spironolactone or eplerenone because, again, those directly antagonize the aldosterone receptors. Next, what's the site of action of the thiazides? So they work in the distal convoluted tubule. And the last question, a patient with heart failure exacerbation needs a diuretic but has a sulfa allergy. So what diuretic can you use? Well, again, loop diuretics and thiazide diuretics are both sulfa drugs. So ethacrynic acid is a loop diuretic we talked about with this one that's not a sulfa drug. All right, that's it for Renal 4. I'll see you next time.
Hello there! Are you ready for another question? If you have a patient with calcium kidney stones, what kind of diuretic should you avoid? Loop diuretic. Remember, loops lose calcium, so your patient may have more frequent stones if you increase renal calcium excretion. A thiazide diuretic, however, might actually help prevent stones since thiazides reduce renal excretion. Whew. All this talk about renal excretion has my nephrons working overtime. Please excuse while I take a little pinkle pause. When did I get the bladder of a 2-year-old?